Hello, everybody, and welcome to our webinar for today. This webinar is brought to you by the National Center for Health and Public Housing. And today we will be presenting on poverty, lack of stable housing, and stigma, the profound effects that SDOH have on addictions. Before we begin, this is some information about the National Center for Health and Public Housing. The mission of the National Center for Health and Public Housing is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration, and is also a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. This is just a quick reminder to everybody that is joining us today that all participants are muted upon entry. Please make sure that you engage in the chat. Raise your hand if you would like your line to also be unmuted. This meeting is also being recorded, and the slides and recording link will be sent to you via email after today's session. And also, we would like to kindly ask the audience, please provide your full name, your title, and what organization you're joining us from in the chat. We would like to know where you're joining us from, have a little bit more information about yourself. And with that, my name is Filipina Sandoval. I am the TTA manager here at NCHPH, and I will also help facilitate the webinar for today. And with me, I also have Dr. Kevin Lombardi, who is our manager of research and health promotion at NCHPH. So here we have some background information about health centers that are close to public housing. According to HRSA's UDA's data, in 2022, there were over 1,300 federally qualified health centers that served to 30.5 million patients. 483 FQHCs were intermediately accessible to public housing that served to 6.1 million patients. And 107 were public housing primary care grantees that provided services to over 935,000 patients. The interactive map to the right also depicts the health centers that are intermediately accessible to public housing and can be accessed through our website at nchph.org. Now we have some data that describes the demographics of residents of public housing. As it is displayed, the 1.5 million residents demonstrate characteristics that differentiate residents of public housing from the general U.S. population. For example, residents of public housing are 52% white, 43% African American, 26% Latinx, 19% are elderly, and 36% are children. Residents of public housing are also disproportionately from households that are low income and female-headed. And now, without further ado, I'm going to pass it on to Dr. Kevin Lombardi.
Hi, everyone. Thank you for your time today. Thank you for your service to your communities. And I'm very excited to hear from all of you and hear from as many of you as possible about this topic today. My name is Dr. Kevin Lombardi. I'm a physician and epidemiologist, and the social determinants of health is one of my areas of research focus. Before we get started, a little bit about the social determinants of health. We'll be focusing primarily on clinical cases and content today, but just to give a little bit of a framework and to give some resources for those of you who would like to read further into the details of the SDOH and its framework. The WHO framework is the foundation and an overarching view of how the SDOH impacts health internationally. In this framework, the SDOH are part of a continuum based on the concept of universal human rights. The WHO framework encourages governments and institutions to further policy changes that lead to better health equity and outcomes through treatment of the whole person. We, the institutions, the FQHCs and the clinical providers are where the rubber meets the road with the WHO framework. Next, please. An understanding of the whole person is a prerequisite to effective healthcare delivery. Trauma-informed and empathetic healthcare delivery requires that staff be given time to support and develop their understanding of their communities. The SDOH provides us a framework for doing this. And we'll be referring to these diagrams throughout the session because they help to allow us to separate the different SDOH services we give in our planning and our implementation. Next, please. Now, here's some basics about the training and technical assistance approach that we'll be taking for this session. Discussion, support, and assistance is the model. Two case-based discussion questions are integrated into the session material. Participants are asked to please write or type their response and to share if they are able. Participants in this session include an incredibly diverse range of clinical and non-clinical professionals from FQHCs, PHPCs, PHAs, and adjacent organizations around the country. This interdisciplinary support is an asset to better understanding ourselves and our challenges as we reflect with each other on the contexts and communities that we serve. The discussion session framework is designed to elicit the main themes and learning objectives and are related to the resources and recommendations that are reviewed in this session. Now, today we will be, one, reviewing data directly from ongoing research at our institution and connecting that to existing clinical and non-clinical recommendations. Honing our skills as clinicians and clinician-adjacent professionals by reviewing case studies, reviewing key takeaways from recent publications on this subject, and disseminating resources and toolkits to help empower you in your practice. And lastly, the most important part is sharing perspectives and support in this interdisciplinary group. This presentation, the slides are designed to be standalone. There are a lot of resources in here and a lot of data. It's shareable. You will receive links, and I encourage all of you to disseminate it or use it however you see fit. Next, please. Some details on the nature of the resources that got in here. Cited resource links are always at the bottom left of the slide. Resources are publicly available and can be shared internally or externally. Cited research is all investigated in detailed manner by my research team. And all of our NCHPH staff members, including FIDE and myself, are available to FQHCs, PHPCs, and PHAs and partner organizations on a pro bono basis as needed. Next. So before we go into the content, I'd like to take 2 minutes and let's call it 1 minute. And if you could all answer as many of these questions as apply to you in the chat. What's the organization you're joining us from? Your roles and professional responsibilities at our organization, your organization, for those of you who haven't answered that already. And the third one, what's one way that you integrate the social determinants of health into your work? I'm going to set a timer for 1 minute and then we'll move on. So we have individuals from a lot of housing authority folks here. Excellent. I see a lot of you have this SDOH at the forefront of your work. It's so encouraging to see. And a lot of use of CHWs. Excellent. Okay, Pete, let's please continue to put that information in for the sake of time. We're to go to our next segment. Next slide, please, Pete. So we're going to start by looking over some data on addiction and on housing and what it says about individuals in public housing and those who are HUD assisted. So the data is from the 2022 Health Center Patient Survey. My team recoded it to investigate the difference between individuals at public housing and individuals who are not in public housing, to take a look at questions related to substance abuse and mental health, and to see if there are differences between the public housing and non-public housing individuals. Could you go to the next slide, please, Peter? Here's the chart. So let's go ahead and break this down so it's a little easier to parse. Next slide, please. So when reading medical review studies, there's a couple of measures to look at. Our 95% confidence interval tells us the 95% chance of real possibility. This is a sample, not a population. So this tells us how inaccurate a measure of accuracy of our numbers. And our p-value, it's our value that defines statistical significance. Anything under 0.05 is considered significant and applicable to the population as a whole. Next slide. And here are our groups. We have our reference group in the orange. That's all patients at FQHCs. Our green is HUD-assisted patients, people who receive HUD-assisted HUD housing choice vouchers and other programs. And the right is our public housing only. Next slide. Now, when I looked at this data, I thought it would be important to put into the session because it says some very interesting things about the public housing population. With very few exceptions, individuals who receive HUD funding, public housing, and housing choice vouchers receivers do not experience higher rates of illicit substance use than the general population. There was no statistical significance found in the use of alcohol, the use of opiates, or the use of inhalants or hallucinogens. Now, this is notable because often the perception of individuals in public housing is that they use these substances at rates that are higher than the general population. This data shows us that that is not the case. Next, please. Now, so the data did show us some very interesting things about screening. Now, if you look at these numbers here, and we'll go to the next slide. The question asked in the past 12 months, have your doctor or other health professional asked about your use of alcohol? And the numbers were very low. What we found that in general, all FQHC patients, only 14.4% reported that they were asked about alcohol use at their most recent appointment. For HUD-assisted and public housing residents, it was even lower, 10% and less than 10%. Now, as a provider who often has needed to put a lot of content into a 15 to 20-minute visit, I can tell you that asking about these things can be very time-consuming. But the data shows us that we aren't asking this quite as often as we should be. Next slide, please. Practice recommendations for this is institutions should have policies regarding the screening of alcohol use disorder. For those of you who are clinicians, consider taking a look at how you ask about alcohol use in your clinical appointments and how often you do. And for institutions, please consider looking at your policies and any training that's provided regarding this. For those of you who don't use the Office Champions model, it's a model that's recommended by the American Academy of Family Medicine, in which organizations can improve their screening by using an Office Champions model. Providers should be trained and retrained regularly regarding the need to screen for alcohol use, and organizations should regularly review their policies regarding AUD screening. For institutions and providers, fitting all of our screening into a short visit can be very difficult. But the data shows us that alcohol use disorder is something that we should be focusing more on. So I encourage you all of you to bring this information back to your institutions and into your clinical practice as well. Next, please. Now, to really understand the SDOH, its impact on housing and addictions, the patient experience and the clinical experience, we're going to be looking at a two-part case study based on a real patient. I'm going to go ahead and read the case, and then we will ask some questions regarding that and have a discussion about the care of this patient. Mr. Angelo is a 47-year-old man who presents for a wellness exam. He has a past medical history of type 2 diabetes and hypertension. The patient has a behavioral health history of major depressive disorder, generalized anxiety disorder, and opioid use disorder. He is in remission for 7 years. Mr. Angelo prefers to receive his medical care in Spanish. Your health center has a large Spanish-speaking population and is in the suburban area of a medium-sized city. The patient undergoes a standard intake, including vitals and an SDOH screener per facility protocol. And here are the results. Mr. Angelo's blood pressure is 178/98. His heart rate is 80, and his respirations are 18. This is in individuals that's hypertensive. A review of Mr. Angelo's medical records indicates the following. In 2018, his blood pressure was notably lower at 138/98. Heart rate of 60 and respirations unchanged. Further look at his medical records from 2018, his last visit indicates that his hemoglobin A1C was 7.0. His drug screen was pan-negative, and he's prescribed the medications metformin and Celexa. Next slide, please. Now, Mr. Angelo filled out an SDOH screener prior to entering the examination room. And here's what the results are. It looks like in the past 2 months, he's had to skip meals because he didn't have money for food. He put yes for homeless or worried that he might be in the future. He noted that he has trouble paying utilities, that he has trouble paying for a ride. Next slide, please. He's unemployed, requests help in finding a better job. He notes that he's concerned about someone in his home is using drugs or alcohol. He notes feeling unsafe in his daily life. And he notes yes for is someone at home threatening or abusing you? Next, please. Mr. Angelo is treated by a Spanish-speaking provider. Upon physical examination, Mr. Angelo is noted to be withdrawn and exhibit closed body language. His responses are terse, and he seems irritated. His physical examination is positive for 1+ pitting edema, so his feet are swollen, and darkened skin around his neck and groin area. New results are positive for a hemoglobin A1C of 8.2. That's 1.2 higher than in 2018. You, the provider, question Mr. Angelo regarding his SDOH screener. And here's what he says. Mr. Angelo worked as a construction foreman until 6 months ago when he was laid off. His unemployment insurance ran out 3 months ago. He's behind on his utilities and his car is not operable. He uses Uber and walks for transportation. Mr. Angelo continues to abstain from drug use, but mentions that his wife continues to misuse prescription opioids. Mr. Angelo and his wife argue frequently about her drug use. These arguments occasionally become violent. He refuses further to speak about this when questioned. And finally, Mr. Angelo has been taking a half dose of his prescription medications because he can no longer afford the medication. Mr. Angelo is asked if he would like to be connected to a facility-based CHW to discuss his SDOH needs. He notes that he prefers to deal with his private life by himself. When asked why, he notes that in the past he has had difficulty connecting with his providers and that he felt judged. Next, please. Now we're going to take a few minutes to answer the following questions. 1, what's your assessment of Mr. Angelo's clinical condition? Is it getting better or worse? And why? And 2, how could a patient like Mr. Angelo be encouraged to seek supportive services? We're going to set a timer for 2 minutes. If you could please put your response into the chat, and at the end, I will ask for volunteers to share, and we will review the case in detail. Fide, for the next 2 minutes, could you cycle slowly through the case study slides so our participants can see? Thank you. And for those, if we have any CHWs or those who manage or work with CHWs in the audience, we're very looking forward to hearing what you all have to say. Okay, Fide, that's a start. If you could take the ball and see if we have folks who would like to share.
Yes, for sure. So we do have a lot of responses in the chat. We have a response from Kayla that says he's getting worse due to the fact he's not taking his medication. He also cannot afford the proper food to help with his diabetes. My apologies on that. And then we also have a hand raised, and also I apologize ahead of time if I don't get to you, but we are trying to maintain the presentation in time. But I will unmute the line for Robert Bowen.
Hi, Robert. Thanks for your participation.
Thank you.
Hi, Robert. How would you like to participate? Do you have any responses to the questions that we have?
It looked to me like it was getting worse, and I would just like to, I work in a primary care provider's office, so I would just link them with that care team.
Hmm. So, Fide, we had someone who, now that we're talking about linking with the care team, I see that Ms. Carol Lemus mentioned a warm handoff, and I thought that might be a good thing to pass to.
Yeah, for sure.
Yeah, see, we're integrated as a family or federally qualified health center. So
Mhm.
I'm part of that care team, and so it would just be a part of that. And it would again kind of depend on what my role is with Mr. Angelo.
Thank you, Robert.
Thank you so much, Robert. All right, so Carol, if you are available, I'm going to unmute your line. If you could please elaborate a little bit more on your response.
I work primarily with homeless and formerly chronically homeless individuals. We're supportive housing and shelter agency, and trust is a big issue. And what we do primarily around that is use a lot of peer-driven programming. Their peers are their neighbors in the buildings in which they live, and know more about them. And then once, I wouldn't do an immediate handoff to someone, but I would have that peer working toward gaining that trust, offering to go with them to speak with the social worker, and so have the social worker really look at connecting them to things like public entitlements, transportation support. Often medical transportation support is available, and then look at his vocational needs.
Now, Carol, you're a regular at our webinar, so it's great to see you again. And my question for you is, I like the focus on trust. In your experience, has working with peers been helpful in getting individuals to access service or to be open to access service?
We started with a peer program for uptake of COVID and flu vaccines, and we implemented it starting with a 12% vaccination rate. And within 4 months, it was over 70%.
Wow, that's a fantastic change. Wow. So
and it was all through their neighbors who were trained as peers.
Well, thank you so much for sharing that, Carol. And for those of you who are thinking of promising practices, peer support networks have been consistently supported in the literature as great methods to encourage folks to take services. Thank you for your input, Carol.
You're welcome.
We have any more hands, Fide?
Not at the moment, at this moment. We don't have any other hands raised, but we do have other responses that were entered in the chat. We do have another response by Rosanna. They said, I would educate him about different resources in the area and encourage him to try a new resource and point out some benefits of having to work with different agencies to help him with resources that may be of assistance to him. Would you like for me to unmute the line for this participant, Kevin, or continue with the next?
If they're willing to share, yes.
All right, Rosanna, if you would like, if you're able to share, I'm going to unmute your line now.
So Rosanna, are you with us?
Can you hear me?
Yes.
Yes.
So what are your
Hi.
So go ahead. I'd love to hear your thoughts about this patient and what you're speaking to here.
All right. Well, I'm working with a primary care setting. I'm working in the primary care settings, and we do have a social services department within the primary care setting. So I'm part of it. So we do meet patients, or they get referred to us by the primary care provider when they found something like that, like patient in need of housing, high blood pressure, going through a different stress in life. So we would basically sit with them, assess the needs and the resources in the area that can help them. So we would refer them and out to those resources in the area, like for housing, food pantries, or anything that can help them. Like with this patient, we know that he's not taking his medication regularly, he cannot afford it. So we can also assess him for the health insurance coverage. Like, is he someone who is eligible for Medicaid, or maybe for Affordable Care Act, or anything? If not, then we would look for program that maybe cover the medication that he needs. We would connect them, we would help him apply and connect them, follow up with him. We would also refer him out to housing. I know housing is tough. I don't know in your area, but in my area, housing is one of the toughest thing. So it's not easy, but we can refer them to agency. They probably may be able to help him move to a new housing, or maybe they can help him pay a couple of months to get him on, on his feet. So that's what I would do.
Now, Rosanna, if I could ask, you mentioned that individuals work with patients that are having social difficulties at your organization. Is that a social worker, a community health worker, or someone different?
I'm not a certified, I'm not a community health worker. I lost my certification, but I do work with patients who uses drugs, alcohol, and substances. And we do have a social worker on board. We have a clinical social worker on board. We have we have different positions. So we do have CACs. We have I'm the only one in who works with the substance use patient. So what else do we have? And it based on the provider referral. So the providers, because we have primary care provider, we have pediatrics, so they would refer them to us if they see the need.
Excellent. Well, thank you for sharing those practice details and for your service to your community. Now,
Absolutely.
thank you.
Thank you.
Let's go ahead and look at this case in detail now. Next slide, please.
I did have a quick question, Rosanna, before we continue. What organization are you joining us from?
I'm working for Family Health Centers of Southwest Florida. We have I think 6 different offices in Lee County, Lee, Hendry, and Charlotte County. So it's pretty large.
Great. Thank you so much.
Absolutely.
That's a fabulous, diverse area, if I might say myself. So thank you for your service. Let's take a look at this case now. Next slide. So just to go over the things in detail, this is the kind of patient that it can be very difficult as a provider to get, because they require a lot of time and they require a lot of concern. Mr. Angelo is coming after not being in the office for several years. He has 2 difficult to control chronic conditions, and his behavioral health history is significant as well. He prefers to take his medical care in Spanish, but this is a facility that is used to and is more than able to deal with his preferences and care. When I look at his blood pressure, it's quite high. And I'm already thinking about medication non-compliance, stress, or if the patient has recently relapsed. So blood pressure is 178 over 98. Looking at 2018, his blood pressure was lower, heart rate was lower as well. And I see his A1C is 7.0, which is high, but meeting criteria for type 2 diabetes, but doesn't itself raise a red flag. His drug screen's pan negative. Next slide, please. And we see his needs are kind of self-explanatory. 2 slides forward, please. Now, where it starts to get complicated, one back, excuse me, is Mr. Angelo's needs. He has been laid off. He doesn't have transportation. He abstains from drug use, but he is in an abusive environment. This is an individual that has significant social needs that are interacting with his medical conditions in a severe way. He's at danger for relapse if he continues to be exposed to drug use and the significant stress that he's experiencing. And he's in need of comprehensive support. He's had difficulty connecting with his providers in the past and he has felt judged. When I see this patient, I see someone who is in need of culturally competent care, and he would be best served by speaking to someone from his community who speaks and looks like him. It's more likely to make him more comfortable and to access services. And for the sake of time, Fide, if we can get down to slide the case study continuity of care to support behavioral health, it's 34 on mine. Now, Mr. Angelo is now seen by a community health worker. Keep going, Fide. Yeah, there it is. So back to Mr. Angelo. Mr. Angelo is contacted by a staff member that works for your facility. He initially refuses assistance, social assistance. The CHW often offers the following resources, which lead to Mr. Angelo agreeing to an initial consultation. 1, Mr. Angelo is told that he'll have his consultation via telehealth. And 2, a community-based Spanish-speaking CHW will be working with him. Mr. Angelo meets his CHW via the facility telehealth mobile application. In the beginning of his appointment, Mr. Angelo has a short introductory session with his CHW, who uses the following techniques to make Mr. Angelo more comfortable during his visit. Next, please. Active listening. The CHW is working to fully comprehend the client through verbal and nonverbal clues. If you remember, Mr. Angelo was very closed. His arms were together, legs were together. He's not making good eye contact. That tells us a lot about the patient and their openness to share information. It tells specifically about their emotional state. Active listening is complete concentration on the patient, allowing them to finish their statements and making good eye contact and making them feel like they are listened to and cared for. Adaptive questioning, starting with general questions and becoming more specific. This allows the interview to feel more like a conversation and relaxes both the provider and the patient. And nonverbal communication. Staying in tune with client posture and body language will send you a long way with working with the patient. Keep in mind, where are their shoulders? Where are their hands? Where are their eyes? Are they making eye contact? Are they not? Next slide, please. Empathy, validation, and reassurance, telling the client that their emotions are reasonable. Mr. Angelo is someone who's noted that he has felt judged in the past. Being able to sit with someone who will listen to him and validate his emotions and his feelings, so that they understand why he feels that way, making him feel reasonable, is therapeutic in and of itself. And partnering and summarization. CHWs often take a coaching approach with the patient. Talking back the patient responses and connecting them to goals can help turn the conversation into real things that the patient will do. People respond very well to a coaching-like dynamic. They feel supported and they feel like people believe in them. And that's really important for a patient like Mr. Angelo, who's dealing with significant social strain. Feeling like he has someone at your organization that's on his team and is from his community can often be the difference between relapse and not relapse, between housing and not housing, because accessing these services takes time, energy, and it can be difficult for folks in difficult circumstances. And finally, transitions and empowerment. Letting the client know what steps are next to help lower provider and client anxiety is really important. Just as you're watching your patient and watching your client as you're talking, the client is reading these things as well from you. And if you exhibit closed body language and poor eye contact, your client will often mirror that. This leads to a positive feedback loop that can be detrimental to the client and patient relationship. When you are talking with your patient, stay as calm as you can, empower them through your language, and this will allow you to open up and the patient to open up more as well. On the bottom left are a link to health assessment interview techniques in detail to helping your training and empowerment as a provider. Next slide, please. Now, he is with his CHW, so per the facility, he has to fill out the SDOH questionnaire again. For those of you who are at institutions who assess social needs, if you don't use an SDOH questionnaire, I strongly recommend integrating one into practice. And in a moment, we'll talk about how you can do that. At the bottom left here is a link to a validated study on the WellRx questionnaire. The WellRx questionnaire has been validated for use in primary care for social services and is similar to the PREPARE study. The PREPARE tool that many of you use. With these screeners, if you do use screeners, consider looking at what the screeners say. Research has consistently validated that institutions have the breadth and the width to alter their SDOH screeners to meet their needs. If you're in a rural area, you may want to ask more questions about transportation on your SDOH screen. If you're in an area that serves public housing, you may have more questions about public housing or resources for public housing that you may want to add to your SDOH screen. If your system uses an SDOH screen, consider looking at the questions you ask and the services you provide, and if there's a gap. And if you would like to go through that process, the link at the bottom left goes through a validated way to do that. Next, please. And next. So back to Mr. Angelo. During consultation, Mr. Angelo's CHW uses the SDOH framework to determine facilities resources. So education and quality, no resources identified for this client. Healthcare access, free transportation to health center via facility van services is identified as a resource for his use, and appointment reminders via facility appointment mobile application. Neighborhood and built environment, he's provided utility vouchers provided from a local community-based organization, and social worker contacts utilities for discontinuation support. Social workers can often make a phone call to speak with the utilities managers to stop discontinuation from happening. And also, this emphasizes the importance of your community-based connections. Connecting with local faith-based organizations or community organizations can often allow you to have access to more financial support for your patients through direct referrals. Take a look at the organizations in your neighborhood and around your patients. Do you have existing partnerships with them? If not, consider starting a conversation. Next, please. social and community context. Mr. Angelo is connected to a Spanish language Narcotics Anonymous meeting. He's provided with drug use recovery literature and resource pamphlets for his wife. And for economic stability, training and support services through the facility Jobs Plus site. And Spanish language peer support groups are the resources that are available for his use. For those of you who have Jobs Plus programs at your institution, thank you for your service. And for those who are interested, and the Jobs Plus initiative provides training and resources for unemployed individuals funded through HUD. It's available for application, and if you click that link on the bottom left, it sends you right to their page where you can apply for that as an institution to provide those services for your patients. Next, please. Now to wrap up, Mr. Angelo has gone through a lot. He's had a difficult clinical appointment. He sat down with a community health worker and discussed and been willing to discuss his resources and been linked to resources. Now, consider this case study and think about your own organization. What program or service at your institution would be helpful in supporting Mr. Angelo? Just put one thing into the chat and we will take one moment to do that. Please take a minute to consider that question, please. Now, Fide, we're at about a minute. Do you think you could ask one of our participants if they'd be interested in sharing? I see some very interesting responses here.
Yes, for sure. Okay, Rachel Jarvis, I'm going to unmute your line. In just a moment. Again, if you're able to share with us verbally,
Thank
more
you
than
for
welcome.
joining us, Rachel.
Hi there.
Hi,
So what do you-
Rachel. Rachel.
Yes.
Okay, yeah, now we can hear you. Sorry.
Did you have like a question?
Oh, yes, I was wondering, yes, could you give us some more details about your response and what your thoughts were?
Sure. So we are a federally qualified health center. We have medical, dental, and behavioral health integrated all in one building. And so we would be able to offer this particular patient. We have, we have LCSWs and clinicians, as well as our care coordination team are really good at being able to connect patients to different services within our organization and in the community. We have peer recovery specialists, and we're able to, meet the patients where they're at in the community or at home and provide support from lived experience and help follow up with resources. Let's see. What else did I put? Oh, yeah. And we have an office-based addiction treatment program so that we could also offer Mr. Angelo to be a part of that program, where we have recovery groups that we can focus on building his, basic needs, a healthy home life, and just building those foundations of recovery to help support himself once he's home.
Thank you so much for sharing, Rachel, and thanks for your service to the community. Sounds like you guys have an incredibly comprehensive set of services under one roof. I noticed that you mentioned homes. Do you folks provide home visits? And if you do, have you had any success in getting patients that may not have gotten care if they didn't have a home visit accept care?
So we, the peer recovery specialists, we're able to visit folks in their home. It's kind of, we do it on a case-by-case basis, just making sure like that we feel safe and comfortable to do so. We've had medical providers in the past that would, they noticed some folks aren't able to come to the clinic as often as they'd like to, so they would do home visits. We currently don't have that provider anymore, but I do think it's really helpful because a lot of the folks we work with don't have a license. We're in a very rural community. It's not really like you can't catch a bus to go here or there. A lot of things aren't within walking distance. So it is helpful that at least us as peer recovery specialists, we're able to either come to their home or somewhere near their home that is close enough for them to walk and meet, to provide the support and services that way.
So if I could ask you one more follow-up, Rachel. You mentioned that you do it on a case-by-case basis, keeping in mind the safety of the individuals. Do you have any details about how that determination is made? Do you guys have, is it on a provider? Does the provider themselves decide, or does the institution have a framework or rules that you have to follow?
We don't really have any specific policy on it. It's really up to us as the providers, and we kind of staff it with, it's an integrated healthcare team. So we're all in this treatment team together. And so we all kind of just will staff it. But if the specific peer provider if we don't feel comfortable or whatever the case may be, like we all kind of support each other in that determination.
Well, I think that's fabulous. It seems like you guys have an incredibly comprehensive set of services you give. So I appreciate you sharing details about that model. And I appreciate your service to the community. Thank you so much.
Thank you.
Pide, could we do one more, please?
Yes, sure.
I so appreciate all of you for sharing these details today.
Okay, I am going to mute the line for Emily Soleo. Sorry if I mispronounce your name.
Hello.
Hello, hi.
So I just wrote, so I'm a grant writer, and I wrote that we would provide recovery linkages to recovery community organizations. So similar to what Rachel just talked about, we have a lot of the similar services, minus the at-home visits. But we also have, we're the facilitating organization for all of the recovery community organizations in our state. So providing Mr. Angelo with linkages to a recovery community organization for both himself and his wife could also be helpful in terms of that peer support. And then I think too, there's also providing him, we also have mainstream vouchers and housing facilities that we operate for permanent supportive housing in our community. So we could potentially provide some linkages there as well.
Thank you, Emily. And if you don't mind, I have a question for you. You mentioned the recovery community organizations and that you're able to refer the individuals to those. Are there, when you say that, are there a variety of different organizations in your area that are better for different types or classes of individuals?
So we, not necessarily, we have recovery community organizations throughout the state that are more regional based. So they're based more on location rather than substance use disorder type. So there's that as well. We also have a partial hospitalization program that we offer, as well as recovery housing for individuals that need it.
That's fabulous. I'm so glad you guys provide that resource. Could you tell us if area of the country you're coming from, and if it's rural, urban, or suburban?
So we're in New Hampshire, and we're primarily located in southern New Hampshire in the Nashua region. So that's more urban. However, the recovery community organizations serve the entire state, and so they're throughout all the counties. We have, I want to say, 14 throughout the state in different counties that are also rural, and we provide services throughout the state.
That's fabulous. Thank you so much for the details. And that is a gorgeous area of the country you're coming from. I hope you enjoy the winter up there. I know it gets
Thank you. Thank you.
So let's go to the next slide, please. We're going to quickly go through some resources here because we are getting towards the end. For those of you who use community health workers, the clinical studies we went over today follow a certain model of where an individual is identified in the clinic using a SDOH screener. They're then connected to a facility-based CHW who's able to follow this system to work with the patient. And intake, goal setting, follow-up engagement, navigation, coaching, and case closure. This is what we just went through, and is a framework for CHWs to work with individuals to help them fill their goals in a trauma-informed and empathetic way. And Fide, for the sake of time, if we could go to the slide on medical legal partnership, please. The presence of a prior conviction for drug use is often a disqualifying factor for housing assistance in many states and in many jurisdictions. And individuals who are facing legal issues because of a drug-based conviction often experience significant psychosocial stress. My recommendation for all of you is to add medical legal partnerships to your list of partners and to actively screen for legal needs in using your SDOH screener. If you go to the left, you can go to a health center MLP toolkit that can walk you through the process of how to find organizations to partner with and how to integrate those into your health center care team. But the perspective that I'd like to give you is that legal services should be integrated into the interdisciplinary care team. Health centers that use medical legal partnerships often put a lawyer directly onto the care team who can listen to the patient details and add their insight and expertise about how the patient's SDOH situation can be improved by sending letters out, cease and desists, and so forth. This can help to stop utilities from getting turned off, to stop individuals from getting kicked out of their housing, can stop predatory loan processes from happening. Having a lawyer on your board, on your care team, and directly working with the patient is a great way to improve the SDOH care of your patients, specifically in individuals who have drug-based convictions or maybe experience a drug-based conviction in the future. If you follow the link, you can go ahead and look at a way to set that up in a detailed manner. And for individuals who would like guidance on how to create those partnerships and how to utilize them, please contact me directly, and I can connect you to organizations in your area and at the national level that may be interested in providing their assistance on the pro bono in a pro bono manner. And Finally, Fide, if we could go to the second, the buprenorphine prescription requirements, please. Now, this is very good news this year. Clinicians no longer require a federal waiver to prescribe buprenorphine for opioid use disorder. This is the MAT Act. A link to it at the bottom left will give you all the details regarding the changes. Here are some of them here. We just found out about this week. It is breaking news and very good news for patients who are struggling with substance use disorder. The presence and lack of enough MAT providers and lack of enough individuals with federal waivers is a major bottleneck to service, and it appears that has been ameliorated quite a bit by the MAT Act. And next, please. And finally, a funding opportunity for rural emergency services training for SAMHSA, application by March 30th. Bottom left is the link to the opportunity. Rural health centers who serve communities in need for expanded pre-hospital medical services should consider applying to this funding opportunity that funds EMS personnel in rural areas that are disproportionately experiencing the opioid epidemic. So for those of you who are interested, please consider applying for that funding opportunity. And if you'd like assistance with that application, please reach out to us directly. And I will pass it to you, Fide, because we are right on the line. Oh, we are over.
We're right at the hour, but if you have any questions for us, you're more than welcome to submit them right now. We can hang around for maybe another 5 minutes. And if we don't have any other questions, then this will be the end of the webinar. But in the meantime, while we wait, I just want to remind everyone that to please complete our post-evaluation survey, which will be provided to you at the end of the webinar. And we'll really appreciate your feedback on today's session.
Fide, if I could add one more thing. We had a question about the medical legal partnerships. In many states, it changes. It's different state by state. In many states, attorneys are required to do a certain amount of pro bono work to maintain their licensure. I believe Massachusetts is one of them. Those resources are different state by state. What I will put in is a link to the National Center for Medical Legal Partnership, which provides as advisors as needed to answer those questions. If you're interested in a medical legal partnership and setting one up, contact them directly and they will help you find the state and regional specific resources. Oh, there it is.
Yeah. Thank you so much. Thank you for providing that. Great. So this is also our contact information here. If you have any questions for Dr. Kevin Lombardi, you can contact him at kevin.lombardi@mgt.com or me. If you would like to follow up about any resources, well, I will be sending out all the slides and the recording link to everyone right after the webinar. This is my email, fida@mgt.com.
And please don't be shy, everyone. We are funded by HRSA to serve you, and we're happy to provide that, always at a pro bono level and always with energy and enthusiasm. So please let us know and don't be shy. And thank you all for your service to your communities and to your patients and for making our country a happier and more safe place for everyone.
Thank you, everyone, and happy holidays.